Afternoon, Prof. Ho. I'm so sorry we're a bit late today. We just the previous meeting just overran a little bit. So everyone, welcome to Congenital Heart Hour. My name is Salim Javanji. This meeting happens every week. We have really interesting talks from speakers from around the world and well-established and well-respected speakers like we have today. Please try to join us virtually or coming here in person. Our meetings are also sponsored by industry. Today, for example, has been sponsored by iCardiology. So we're really grateful for all the support that we get from them. Next week, we have a meeting which I'm going to confirm at the end of the talk. So today I've got the honor of reintroducing Professor Yen Ho, who's been going through the series of cardiac morphology. Today should be talking about aortic, pulmonary, tricuspid, and mitral valve malformations. And thank you very much and welcome.
Thank you very much, Salim and Dr. Salim. I'm going to carry on with cardiac morphology today, looking at the valves and the valve malformations. If you have any questions, please do not hesitate to put them into the chat or the Q&A. Don't know why. Okay. So we're going to start off with the aortic valve. But for every valve, we need to consider not just the leaflets, because particularly for the semilunar valves, I think we should look at the root of the valve, and we should also look at the location where the valves are and the components that make up the valve. And importantly, in this day and age of transcatheter intervention, I think it's very important to recognize what the important structures are in the neighborhood. And of course, there are variants. So we start off with the aortic valve. Where is it located? You can see from the front of the heart already, this is the pulmonary outflow tract, pulmonary valve, pulling forward the pulmonary trunk. We are looking now upon the aorta, the aortic root, I call it, because we have the origins of the coronary arteries from these bulging aortic sinuses. You can see how the tubular part of the aorta is there, and this is the bulging posterior or non-coronary aortic sinus there. And I've pulled back the left atrial appendage. You can see the left coronary artery, you can see the great cardiac vein, and so on and so forth in this region, so-called it's the summit of the left ventricle. And turning around a little bit, we can now peer into the mitral orifice, the anterior leaflet, the posterior or the mirror leaflet, and anterior and posterior, anterior medial commissure rather. And here we see the aortic root, don't we? And we're looking actually, here's the tricuspid valve. And so we have the atrial septum coming straight to the back of the aortic root. So that's very important to bear in mind if, say, you're doing interventional procedures upon the atrial septum. So now a still image, similar situation, looking from the front of the heart. I've taken away the pulmonary outflow tract, taken away the pulmonary trunk, exposing for you the arrangement of the aortic root with the bulging aortic sinuses. We see the coronary arteries here coming up, and then we have the tubular portion of the aorta. And the borderline between the sinuses and tubular portion is simply termed the sinutubular junction. In looking at the origins of coronary arteries, we can see that in this anatomical study we made, albeit not that many normal heart specimens, the orifices of the coronary arteries tend to hover around the level of the sinutubular junction as depicted on this simplified diagram. Now looking at the aortic valve from sort of posteriorly and from the right aspect, we see then the two facing aortic sinuses, giving off the left and the right coronary arteries, are the nearest ones to the pulmonary valve. And I've pulled forward the subpulmonary infundibulum just to demonstrate for you that the level of the pulmonary valve and the level of the aortic valve are not similar. And indeed, looking, these are measurements it made again on the pathological series. looking at these coronary aortic sinuses of Valsalva, there's the bulging parts of the largest and highest in the right, smallest in the left, smallest and shortest. And with this disproportion in the normal situation, even you get a tilt of the plane of the sinutubular junction to the plane that joins the bases of the sinuses. There's a tilt of about 11-degree difference between them. If you look more closely at what constitutes the aortic sinuses, we see here the sinutubular junction marked in dotted line, and we have the zone of apposition marked out here, which is also termed the luneal, and this kind of thickening in part of it. Sometimes in this region, in the older specimens especially, we can find fenestrations, but they pose no problem because these are the zones of apposition, so one leaflet abuts upon the surface of another leaflet, so that seals off any fenestrations, in other words. We have the nodule of Laurentius, which is the thicker part in this zone of apposition. And then we have the hinge line, which sort of forms semilunar shapes according to the shape of the semilunar leaflets. This is the term, the so-called annulus, and you appreciate that it is not a ring configuration. And then of course, we have the hemodynamic junction between the leaflets and the ventricular walls, for example. So taking a heart in longitudinal cut, and you're familiar with this, I'm sure, you're more or less your transesophageal kind of long axis view. We made histologic sections serially through. We can see up here the sinutubular junction, beginning of the sort of commissurous part between the leaflets, and then the leaflets separate as we go deeper down into the aortic root. And finally, we're in this sort of situation where we have opening up between the leaflets fibrous tissue compared to elastic tissue, which is darker stained, fibrous tissue more in reddish rather than darkish staining. And these are, of course, the interleaflet fibrous triangles. And we have not a circular hinge line or annulus, because a circle would not give you that sort of movement of the valve when it opens and closes. So we have semilunar hinge line, and in between them, we have the interleaflet fibrous triangles. So looking at this specimen, which is prepared simply by taking away the aortic sinuses, you see the pointed parts here. These are the regions of the fibrous trigon, aren't they? The valves will open and close. For some reason, this movie doesn't seem to want to work. Apologies for that. So on imaging, you can actually see this configuration, this crown-shaped configuration. Well, what about the relationship with the atrioventricular conduction system? This is a view from the apex of the left ventricle, open up the septum here, the free wall of the left ventricle, the mitral orifice here. We can see the region of aortic and mitral fibrous continuity. In other words, no muscle between aortic valve and mitral valve leaflets. And the atrioventricular conduction bundle would be coming through from the central fibrous body, emerging here, and draping down the left side of the ventricular septum would be the left bundle branch. We look at a similar kind of dissection, a long axis view, parasternal long axis view simulated. We can identify the membranous septum in this dissection, and we can identify also the atrioventricular conduction bundle encased in its fibrous tissue sheath, which gives this sort of whitish sheen to it. And we can see now the location of the left bundle branch and the branching bundle. In this case, a little bit of muscle in between, meaning that the bundle is slightly more to the left side of the ventricular septum. And the histologic section of the heart is in a similar orientation, cutting through here, for example, shows the membranous septum and a close proximity with atrioventricular conduction bundle, splitting out in right bundle and left bundle branches. And this is important to bear in mind when doing procedures like the TAVI, transcatheter aortic valve implants, because you can, in some patients, create a heart block, for example, a left bundle branch block, the various range of incidences given up here. So the structure of the aortic valve should include the aortic root, so include structure of the leaflets, how well formed they are, the number of leaflets, the aortic sinuses, how are they, tubular portion of the aorta, and of course the surrounding structures, immediate subaortic region. So having seen the normal configuration, we can then consider what's the stenosis, the substrate of stenosis. So in terms of number of leaflets, you can have variance as depicted here. So for example, starting with 3-leaflet aortic valve, perhaps, you might have this sort of configuration, a normal aortic valve, spastic unequal leaflets, or thickened mucoid degeneration. Or you may have 2 leaflets, where you have the 2 commissures, but the third one has not formed. You have a raphe. As we go deeper into the same valve, you find it sort of communication between the ridge of the undivided or unseparated leaflet to the raphe. But interleaflet triangle in this region is very much diminished. So diagrammatically, we show you here then in the normal configuration, the regular height of the interleaflet fibrous triangle. But in bicuspid aortic valves, you may get this sort of configuration, for example, with a diminished interleaflet triangle, reduced height, meaning that the valve leaflet might be less able to fall back into the aortic sinuses and therefore can be causing the substrate of stenosis. Now, more 2-leaflet aortic valves, examples here, well-formed raphe, less well-formed raphe, and hardly any raphe in this particular case. And indeed, you can have bi-leaflet aortic valves without any raphe. For example, in these cases here, this one here, quite slightly different lengths of the valves, no raphe. This one from sort of teenage patient. Actually, the leaflets are very, very much thickened and stiff. I think that was the substrate for stenosis. In this example, it was associated with a narrowing of the aorta at the sinutubular junction. Then we move on to those with 1-leaflet configuration, the unicuspid, unicommissural type. You may have this sort of configuration. You may have this kind of configuration with some attempt to form commissures as depicted in this particular specimen. The dome-shaped valve in aortic position is less common than in pulmonary position. So figuratively, it's depicted as here. This is just an example. Then you may have even an atretic membrane blocking off the exit from the ventricle below. And in our museum, then, we have 4-leaflet configuration even. And these are said to form more regurgitation than stenosis. So in terms of the aortic root, I think I just briefly want to bring in the supravalvar region also, because it's actually part of the aortic root. So in terms of aortic stenosis, for example, you may have supravalvar and in terms of valvar. I think supravalvar very much incorporates also the valvar part. So just briefly then, you may have this sort of configuration, the hourglass configuration, a diaphragm type, or a diffuse type of configuration. But most of these would also involve the leaflets, the aortic sinuses, and the sinutubular junction. So if we take a look at this one, for example, there's a kind of waist-like hourglass appearance, isn't it? See the aortic sinuses and sort of narrowing right at the sinutubular junction. The aortic leaflets are kind of redundant looking, if you like, but they seem to be narrowed in this particular heart up here. And actually, we see the coronary orifice coming from this sinus, which had actually been blocked up. So the close-up views here, we have actually in this particular heart an isolation of the coronary artery orifice here. The free margin of the leaflet had actually been sort of stuck down onto the top of the sinutubular junction. In this example, then, is a diaphragm configuration of stenosis. So presumably the surgeon could go in and resect away the diaphragm and all would be well. The diffuse hyperplasia is shown in this specimen here. You see kind of bulging aortic sinuses, kind of thickened aortic leaflets, but the aortic wall itself is very, very much thickened. See here where the head and neck and arm arteries are, very narrow kind of lumen. And this is a situation of so-called macaroni arteriopathy. So it can be familiar, as described in these publications here. So in other words, and what I'm trying to say is the valve is a composite of component parts, and it's not only the leaflets we need to consider. So moving on now to the pulmonary valve. We first look at the normal right ventricular outflow tract, and then we look at some of the examples of normal and abnormal pulmonary valves. So to start with then, this is the right ventricle opened up, the tricuspid valve here, and you're looking up, trying to get access to the pulmonary valve. In this region of the right ventricle is the region of the ventricular infundibular fold, and carrying on is the crista supraventricularis. I know there's been very various terms, different terms in different countries given to these terms, to these entities to describe this particular area of the heart. The supraventricular crest, I think, is quite often used as well. But up here, all it is muscular separation between pulmonary valve and the tricuspid valve. We take another heart and we look up here and enlarged here. We can see the so-called ventricular infundibular fold here is not the septum, is it? Because I've cut through the ventricular infundibular fold and you see straight away the aortic sinuses. This is the right coronary aortic sinus with the right coronary artery already. And over here with a pulmonary valve, and here with the free wall of the right ventricle. So in other words, the pulmonary valve and tricuspid valves are well separated apart. There's no fibrous continuity between the two valves, and hence the pulmonary valve is supported entirely by this infundibulum or cone-shaped muscle, funnel-shaped muscle in the right ventricular outflow tract. And note here, just behind here, is the course of the left anterior descending coronary artery already. So taking another heart and removing the pulmonary valve leaflets, we can see here the borderline between the brownish tissue, which is the muscle of the right ventricle, separating it from the arterial wall of the pulmonary trunk. So this line represents the ventricular arterial junction. And similar to the aortic valve, the annulus is not a circle, is it? You still have the three-pronged crown arrangement. Ventricular arterial junction, yes, that is a circle. And if you draw a line joining the tips of the commissures, you get a signing tubular junction, which is a circle. But the annulus itself is not a circle. You need that movement between these prongs. So we're just going to look at the leaflets, the commissures, the orifice, and the signing-tubular junction. And to start off with, then, we have 4 leaflet configuration in these 2 specimens in the museum that I'm sitting in today. Again, they can give you stenosis or regurgitation. The leaflets can be very unequal in size. Then those with 3 leaflets, these examples just show you the thickening of the valvular leaflets. This one, they tried to think this one was one of the first cases. They tried to balloon open to make it a lot less stenotic, but it's the leaflets themselves that are very, very much thickened. Here we have a rather unusual, not at all common kind of configuration, an hourglass configuration for the pulmonary valve stenosis. These are examples of bicuspid pulmonary valves. You see here a partial commissure fusion here. It's depicted here. And this one, unequal leaflets. And this, on the other hand, at the far right picture, is a keyhole type of configuration, unicommissural and unicuspid, the kind of formation we've seen already in aortic valvular stenosis. But more commonly, I think the pulmonary valve, when it's stenotic, will show this kind of configuration instead of a unicuspid configuration. It's more or less like a dome-shaped kind of valve is depicted here. In this heart, a very tiny pinhole in this dome. This one also with shallow sinuses, but you may have those with deeper sinuses as shown on this other histologic section here, depicted here. The imperforate pulmonary valve is shown here, associated in the case with pulmonary atresia with intact ventricular septum, actually. See here? Not even a pinhole at all. It's totally imperforate. On the other hand, you may come across absent pulmonary valve syndrome. This example, all that means is that at the position of the pulmonary valve, you don't see the formation of a semilunar leaflets. Instead, you find a ridge-like configuration of sort of mucoid kind of tissue. It varies tremendously in size and in distribution. But the end result of it is that it's stenotic and it's a very regurgitant valve, meaning that you can get dilatation of the pulmonary trunk plus dilatation of one or both of the pulmonary arteries. And this is endocards, trachea and main bronchi, together with the dilated pulmonary arteries, just to demonstrate this sort of squashing of the airways by these hugely dilated pulmonary arteries. So the configuration, you may have stenosis, regurgitation, and so on. But if you have a 3-leaflet valve, as shown here, you may have dysplastic leaflets, as we depict here. And you may have parachute-like configuration. You may even have multiple orifices affecting this tricuspid valve. In this series, in these examples of the tricuspid valve, we have, it's shown you here, all these pictures were taken from a series that we looked at hearts with hypoplastic left heart syndrome. So the thing is that it's important, we think, albeit we're talking about a post-mortem series, I think it's important to kind of review what the tricuspid valve is like if you're going to use that as the ventricle as the main pumping chamber, for example. So for tricuspid valves, we will see you can have affecting the leaflets, you can affect the chordae, with this fusion of the interchordal spaces. You can have very short chordae, for example, in this particular example. And here we have parachute configuration because there's only one free muscle here. The chordae have obliterated themselves. There's one chunk of peripheral muscle in here. So for me, would be a parachute configuration. In this example, we have joining together of facing leaflets of the tricuspid valve, giving you separate orifices. This one is the main orifice, this arrow, and this is another orifice. This is much smaller, tinier orifice. So configuration of tricuspid valve to bear in mind, not just the leaflets, but the chordae and the papillary muscles as well. In this example of tricuspid valve, looking from the right atrium, we can see the flow of the right atrium there. There's a small right ventricle. This is an adult-sized heart. And I'm trying to put a torch into the small right ventricle just to show you we actually have an imperforate tricuspid valve. So diagrammatically then, we depict it as that sort of situation. It's not an absent connection because there's a valvular membrane there. And Epstein malformation is, of course, a very important part of tricuspid valve malformations. There are lots and lots of variations. It's sort of described as a lack of delamination of the valva, of the forming valvar leaflets, lifting off from the surface of the inner surface of the ventricle. For example, in this case, we have dotted in here the tricuspid valve annulus separating the atrium from the ventricular tissues. So it's passing down here. And you can see that we have a fairly well-formed anterior superior leaflet in this particular heart, but it's deeper than we usually find. In some cases, you may have multiple leaflets forming the anterior superior part of the so-called leaflet. The septal leaflet is only represented by this area here. Much of it hasn't really developed well, especially when you look down here. We can see that we see leaflet tissue here, but we don't actually see leaflet tissue along here, do we? So we're saying that although this part of the leaflet is lifted off from the septal surface, this part of the leaflet hasn't. So it's a reduced separation of the leaflet from the myocardium owing to lack of delamination, such that the leaflet itself is not fully mobile up to the level of the atrioventricular junction marked by the dotted line here. And this is part of the inferior leaflet. Part of it is lifted up, but part of it is still has not lifted up, so-called stuck down. So the area that is affected in Epstein malformation is usually in the septal leaflet part and the commissure region with the inferior leaflet. There's another example showing a more severe Epstein malformation. You can already recognize in this infant heart very, very dilated right atrium. Dotted line marking the atrioventricular junction. Anterior superior leaflet, a bit deeper than I would expect in a normal. The inferior really haven't formed all that well. A little bit of septal leaflet here, but far from the atrioventricular junction. So the lack of coming up to the atrioventricular junction is quite severe, one would say. If you make a 4-chamber kind of view here, you will see that the septal leaflet, for example, would be much, much lower down compared to the level of the mitral valve or the level of the normal insertion of the tricuspid valve. So in this case, we have also, if you look on the free wall of the right ventricle near the inferior leaflet, for example, it's almost paper thin, isn't it? And this zone is described as atrialization of the right ventricle, but it's actually ventricular myocardium. It's just a lack of thickening of that wall. As I said, Epstein malformation is has a huge range of variations going from minimal to severe, as you see in these two specimens. And also, personally, I would say that no two Epstein tricuspid valves are the same. So we move to the mitral valve malformations. You have the stenotic valves, the imperforate valves, and the regurgitant mitral valve. Some examples to show you here. So we start off with this example, looking into the left atrium, the left ventricle, opened up the mitral valve, pull it apart. See the peppery muscles here, one group here and the other group there. Very, very short commissures, obliteration of the commissure spaces. So plus thickening of the valvar leaflets. So dysplastic valve giving you mitral valvar stenosis. In this example, you will see dilated left atrium. Here is the mitral valve. So we have two groups of peppery muscles, still the same as in the normal, but the tips of the peppery muscles have basically joined with the free edge of the mitral leaflets. So you don't have any free edge of the mitral leaflets at all. You hardly see any chordae. So the peptic muscles have more or less formed an arcade around the basis of the mitral leaflets in these two diagrams. I show you this arcade formation. It can give quite severe mitral stenosis. This is just an example of a parachute mitral valve. Can take two configurations. In this particular one, the peptic muscles are fused together. So it's this form of parachute mitral valve. And you can also imagine that when you have flow coming in, the flow is dependent on the intercaudal spaces in order to get into the cavity of the left ventricle. The other form of parachute mitral valve has been described as one with a hypoplasia of one of the peptic muscles in this configuration. So both are termed parachute mitral valves. If you take that sort of situation one stage further, then you might end up with something like this. One group of peptic muscles, so parachute, but an imperfect mitral valve. You can just about see the top of the peptic muscle just there. But the mitral valve leaflets have not really formed. You get an imperfect membrane in the position of the mitral valve. So mitral atresia, isn't it? And moving on to this configuration, it's not stenosis, but we have two orifices to the mitral valve, isn't it? One here. If I put these two bits of the right ventricular wall back together, you have another orifice. So viewed from the aortic outflow tract viewpoint, we have two orifices coming into the mitral valve. And that reminds me very much of the mitral clip configuration, isn't it? For mitral regurgitation, and now adopted, I think, in the tricuspid valve position as well. But this is a natural dual orifice mitral valve. And in this particular situation, we are talking about an isolated cleft. See here, where the anterior leaflet of the mitral valve should be complete here, but instead we have a cleft in it. And this cleft in the normal mitral valve actually points towards the aortic outflow tract. It cannot be the equivalent of a cleft, for example, in an atrioventricular septal defect, isn't it? So this is isolated mitral cleft, giving you regurgitation, isn't it? Oh, you may have this configuration, a straddling mitral valve. So part and parcel of mitral valve malformation, isn't it? See the orifice here, mitral valve, going over the septum to the right ventricle side. And when the mitral valve straddles, unlike the tricuspid valve, when the mitral valve straddles, in my experience, they tend to go over the anterior part of the ventricular septum, whereas when the tricuspid valve straddles, it tends to go more to the posterior inferior part of the ventricular septum. So that ends my talk on valvular malformations. So I think the take-home message is just valves are more than just leaflets. So we're to remember all the support apparatus of the valve itself and what's around the valve, very importantly. There's still pictures of the museum I'm sitting in. If you happen to be in London and wish to see it, drop us an email, and if we are in the museum, you're very welcome to come. Hello. Thank you very much. This is just our QR code for our courses. We run courses throughout the year. In this particular one, we do maybe about 5-6 times a year. It's a webinar, half-day webinar, taking about 3 hours. Okay. So thank you very much for having me. I hope this series of cardiac morphology talks have been helpful to you. Thank you and goodbye.
Thank you very much, Prof, for really nice talk. I'm just going to wait for the audience to see if they've got any questions. Khalid. So I just wanted to ask you a couple of questions. One was in your slide about the tricuspid valve, where you put a torch through it and you described it as that there was a connection. Would you describe it as an absent AV connection, a tricuspid atresia? In terms of nomenclature, it's just nice to know how to describe some of these things. There's also an interchangeable use of, for example, permeatresia. I'm quite strict in terms of saying that if there's flow through the pulmonary valve, I say it's critical pulmonary or permeatresia. So what is your take on that?
My take on atresia is I don't like the term very much, unfortunately, because atresia means a total blockage of the flow. Okay? But the substrate of it in imperforate valve is different from an absent valve. So, for example, you have so-called very commonly in univentricular atrioventricular connections. Say in absence of the right atrioventricular connection, a lot of people would just call it tricuspid atresia and be done with it. Yes, it's a very nice short form, but the valve hasn't formed at all. There's not even a membrane to tell you it's a valve. So how can you sort of surmise that would have been a tricuspid valve? That's my take on it. And I would say we need to distinguish the muscular form of atresia, which would be, say, in an absent connection situation, distinguish that from an imperforate valve, which may be a concordant atrioventricular connection, or may indeed be a double inlet atrioventricular connection.
Right. Okay. That's quite interesting to know. And what about permeatresia? Similar. I mean, it's the same thing, isn't it? So if you have an imperforate permeate valve, you'd call that permeatresia. But if there's flow through it, even if it's a few cells of blood going through it on echo, would you classify it as an atresia or a?
Well, the thing is, morphology is based on what we see, not on flow, essentially, isn't it?
Right.
So we can't see the few cells through, so we say atresia. If we can see even a tiny little hole, then it's severe stenosis.
Right.
Right?
Yeah. No, that's basically what I'm alluding to. It's just nice to have that clarity and also having it a bit more refined in terms of how we describe things. We do tend to use a lot of explanation and description, which makes it easy for us to understand, but it doesn't give a clear picture for what we expect to happen with the heart as it grows. So does anyone have any other questions? Yeah, Khalid, one of our registrars got one. Sorry?
I was going to ask what the difference is between the supraventricular crest and the ventricular infundibular fold. When I look at when I read on morphology in the books, it almost looks like it's the same to me when I look at the illustration and stuff.
Did you hear the question?
No, I can't hear.
Do you want to?
Yeah.
Come on here. Okay. Come on, take here. On.
I just wanted to ask about the morphological difference between ventricular infundibular fold and the supraventricular crest, because when we look at the diagrams, when look at kind of a Dove-Toff diagrams in textbooks, they seem to it looks like they use the terms interchangeably. So I just wanted to ask about the difference between the two.
Yes, that region of the heart is a problem in terms of nomenclature. We know that we call things that people in North America call them differently. And that's always a lot of confusion. That region of the right ventricle, we would say, is a region of the supraventricular crest. But then if you look through the literature, the crista supraventricularis really describes the juncture of the ventricular, what we call the ventricular infundibular fold, to the septum itself. That's between the limbs of the trabecular septum marginalis. So I would say, to be helpful, I would say, don't worry about all these big names and terms, so long as you within your team understand each other. That's more important than I know there are people who love debating and writing lots of papers about terminology. I'm afraid I'm not one of them. I say, if you understand between you people, your team, that's the most important thing.
Good. Thank you very much. Always an excellent talk, Prof Ho. Have a nice summer break, and then we'll catch up September onwards. Thank you so much.
Thank you. Thank you very much.
Bye.
Bye.